The GeriPal podcast is brought to you by Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
Welcome to the GeriPal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we are delighted to welcome Liz Whitlock, who is Assistant Professor of Anesthesia and Perioperative Care at UCSF. Welcome to the GeriPal podcast, Liz.
Thanks so much.
And we have Mike Rich, who is Professor of Medicine and Cardiology at Washington University in St. Louis, which is distinct from the University of Washington in Seattle. And is also has a long-standing interest in geriatric cardiology as one of the early movers and shakers in the field. Welcome to the GeriPal podcast, Mike.
Well, thanks, Alex, and thanks for having me.
I'll also say that Mike is additionally one of the associate editors at the Journal of American Geriatric Society and has been involved there for a long time.
We're going to be talking about journals. We're going to be talking about Liz's paper that just got published in JAMA on CABG versus PCIs and memory decline in older adults undergoing coronary revascularization. And in general, kind of the idea of like, what is geriatric cardiology and geriatric anesthesiology? So we got a lot to talk about. But before we get into that, we always start off with a song request. Liz, do you have a song request for Alex?
Well, Alex, I thought based on the topic of today's conversation, perhaps How Can You Mend a Broken Heart by the Bee Gees would be appropriate.
All right, just a little bit.
I want to hear this one.
Stretching my vocal range here again. I can think of days when living for my life was everything a man could want to do. I could never see tomorrow, but I was never told about the sorrow. How can you mend a broken heart? How can you stop the rain from falling down? How can you stop the sun from shining? What makes the world go round? How can you mend this broken man? How can a loser ever win? Please help me mend my broken heart and let me live again.
That was fabulous, Alex. I remember I watched the Bee Gees documentary a couple months ago. Fascinating. 3 brothers from Australia.
Oh, I didn't know they were brothers. Oh, they don't look like brothers. The YouTube video I saw.
I didn't know they were from Australia. I thought they were from UK.
Huh?
I thought they were from, it was a while ago. It's been a couple months. I thought they were from Australia. I could be wrong. Well, how about we move from the Bee Gees to mending broken hearts? Liz, I'm going to start off with you. We always talk about, first of all, big congratulations on the JAMA paper. Really amazing. We're going to talk about that JAMA paper, but we always like to hear, how did somebody get interested in this type of work, especially around your publication with whether it be geriatric cardiology or geriatric anesthesiology for you, Liz?
Yeah, so I did a fair amount of research in medical school, was actually one of the co-authors on this paper, and yet had a very kind of poor grasp in medical school, of course, of what it's like to be an anesthesiologist and what sort of things patients would bring to me as far as their concerns, and the reality of postoperative recovery for older adults. And what I started to be struck by in residency was that the reality of recovering from major surgery for older adults seemed a lot tougher than I had appreciated as somebody who had kind of a tangential participation in the postoperative care. There are some things we can do intraoperatively to help older adults, but fundamentally, I started to be really interested in making sure that major operative interventions were aligned with an older adult's goals, that they had a really good grasp of what they were getting themselves into, that they knew what the anticipated risks and benefits of the surgery were, even sort of amorphous ones like cognition, which is what we're going to be talking about later, and kind of helping older adults understand what it might look like for them as they recovered from a major surgery. And certainly CABG revascularization is a major surgery indeed.
And Mike, how about for you? How did you get interested in the idea of geriatric cardiology?
Well, when I did my cardiology fellowship back in the early 1980s, my original interest was in acute coronary care. That was a really hot time in cardiology. That's when thrombolytic therapy and angioplasty first became available. But when I was working in the CCU, we were having a pretty high volume of older patients with acute MI and acute coronary syndromes. Upwards of 50% of our patients were over the age of 70, 20% were over the age of 80. And I went to the literature to try to see what we knew about acute MI in this age group. There was virtually nothing published. And that's how I originally became interested. I thought it was a real opportunity to do some important work to contribute to the field, and later evolved into interest in heart failure, atrial fibrillation, other areas of cardiovascular disease in older adults.
I wonder, Mike, because you've been around for this, the development of the field of geriatric cardiology, if you could give us an overview of what are the like sort of hot button issues in geriatric cardiology? I don't know if that's the right term, but like what is different about older adults and cardiology? And you mentioned a few, acute coronary syndrome, anticoagulation, heart failure. What makes cardiology in older adults different?
Well, I think that perhaps the most important thing, as in medical care for older people in general, is that the complexity of the condition as well as the treatment becomes increasingly great as people get older, with more comorbidities, psychosocial issues, family issues, and so forth. But also, aging is associated with substantial changes in cardiovascular structure and function, which alter responses to disease and to treatments for disease. And so I think that it really takes a much more nuanced and patient-centered approach to really provide optimal care to the older patient with any condition, but particularly cardiovascular disease, which is my area of interest.
And for our listeners who may be practicing geriatricians or clinicians caring for older adults, when should they think about, like, when they refer, can they refer to a geriatric cardiologist? Or is that only in, highly specialized centers like Washington University?
Yeah, there's quite a few. There's in the American College of Cardiology, there's a geriatric cardiology section, which has some 1,000 to 1,200 members. And if one wants to identify a local geriatric cardiologist, it's possible to search the database and try to find someone. But the truth of the matter is that pretty much all cardiologists are reasonably well versed in the care of older patients, for the simple reason that a large proportion of our patients are older. And I think that in recent years, there's been greater awareness amongst cardiologists about some of the truly geriatrics issues. And that has been stimulated in part by the emergence of TAVR as a therapeutic option for older patients who previously were considered inoperable, or for whom there was no good treatment option for severe aortic stenosis. And we've learned that even with TAVR, that older individuals who are frail or who have poor functional status aren't necessarily going to get a good result with TAVR. Even though you can fix the valve, you can't necessarily fix these other issues. And so I think that that's for a large proportion of cardiologists put aging and geriatrics and frailty on their radar screen, and it's something that they will consider in deciding whether or not to refer a patient for TAVR or any other type of invasive procedure, including CABG.
And you mentioned TAVR. Eric's going to talk to, I guess, by the time this comes out, the literature update will be over.
Yeah, I think Ken's going to be talking about functional status after TAVR
at the AGS plenary. And for those of you who didn't see it, you can catch it online. And then the song to go with that is My Heart Will Go On. Sternotomy, TAVR, whichever I get. I believe that the valve will go on.
Alex, you had asked earlier some of the hot button issues in geriatric cardiology, but function is one of them, definitely. How do we optimize function in our cardiac patients? Sort of almost de-emphasis, although certainly not completely ignoring longevity in talking about the impact of our therapies, but trying to optimize function, which tends to be of great importance to our older patients.
Yeah, and keeping in mind, when we're talking about function, we're talking about physical function of the person as opposed to optimizing cardiac output, which may improve physical function of the person. But I think helping cardiologists see that the bigger picture is one of the important contributions that geriatric cardiology has made to the field.
And that's why I really like Liz's JAMA paper, because when we think about outcomes in cardiology, it's not just about survival that older adults care about. They care about their physical function, and they also care about their cognitive function. And how about we get into the paper right now, which I think is fascinating, looking at memory problems, because my bias, I guess, was, this is a no-brainer. Like, older adults are going to do better with a PCI as far as cognitive function. Like, why? Like, what's the big deal here? Liz, I'm going to turn to you. Why did you even think or conceive of this paper?
Well, so here's the thing. We anesthesiologists have been mulling over postoperative cognitive change or postoperative cognitive dysfunction for decades. And as a thing, it was sort of first demonstrated after on-pump major open heart surgeries, where first, people were looking at the cardiac bypass pump as maybe causing long-term cognitive deficits. You could identify cognitive decline in something like a quarter, maybe more, of patients following their CABG surgery. And people were saying, this is awful. This is a public health problem. We are harming older adults by doing these procedures. And it trickles down, where news media presents an anecdote of somebody who really had a terrible cognitive outcome after surgery, and couples it with evidence looking at cognitive testing in a large population of older adults. And then the morning of surgery, a patient comes to me and says, hey, I heard, or I know somebody who had really bad cognitive outcome after surgery. Mm-hmm. And they're coming for, maybe they're coming for a major cancer surgery because they would hope to have another 4 or 5 years of life instead of 6 months. Maybe they're coming for a knee replacement where they've been functionally impaired for years, maybe on opioids, uncomfortable, not exercising. And they say, hey, what about this thing that might happen to my head? And it's really difficult to reconcile because you want to be helping people. When I take somebody to the operating room, I want to know that the surgery is going to help them achieve their goals, whatever those are. And if I can't talk intelligently about the risk of cognitive decline and how cognitive change after surgery might fit into somebody's long-term cognitive outcome, I'm underprepared to kind of explain to them what to expect post-op.
And isn't there some guideline from some professional society that you're supposed to talk about cognitive outcomes? Yeah.
Well, we've got some guidance that's been published in major anesthesia journals that we should be talking about. First, delirium, immediate postoperative cognitive change with people who are at risk, but then also potentially longer-term cognitive change in all older adults, 65 and older, the risks of it. And I'd love to be able to do that. It seems like the right thing to do. The people who wrote these guidelines are people who are immersed in this literature. But I ran into a problem where I could tell you that, you have a 15 to 20% risk of scoring 1 to 2 standard deviations lower than your predicted postoperative cognitive outcome at 6 weeks or 3 months or something like that in there. But I couldn't tie it back to being able to, read the newspaper or find your keys or other things that are important for life. I could just tell you about standard deviations. And that to me didn't feel like consent. Like it didn't feel like a conversation about what mattered.
So can you describe a little bit about what you did in this paper?
Yeah, so we used a population-based cohort of older adults in the health and retirement study. And these are older adults throughout the United States who said, hey, go ahead and call me up every couple of years and ask me, hours of nosy questions or in person. And they get cognitive testing as well. And every 2 years, kind of no matter what happens to them as they age, the HRS contacts them and sees, checks on how they're doing. And they do a battery of fairly simple cognitive tests. And in the course of normal medical care towards the end of life, some of these older adults had open heart surgery to revascularize, coronary artery disease. So they had CABG surgeries. And some of them had PCI, so a much less invasive intravascular version of opening up those blocked heart arteries. And so we collected the people who had CABG or PCI procedures, and we looked at what happened cognitively to them after their procedure, but also before, because we had that data just from their participation in the cohort.
And I guess my question is, are these comparable groups? Like, I would imagine the groups that are getting CABGs are different than the groups that's getting a PCI. I'm trying to figure out which way would be worse. I mean, I think if they're sicker, they'd probably avoid CABG, and they're healthier. I don't know. How should I think about this?
Well, there's definitely a cardiological reason. You don't go and do a CABG on somebody that you could revascularize using a PCI. Usually, the people who get CABGs have more severe. I'm sort of not in my lane here. There's a cardiologist on the Hollywood Squares view right next to me.
But it's probably like a bell-shaped curve, right? Or a U-shaped curve. Like, less cardiac complications, issues, you're probably getting PCIs, but the sicker you are, you're also probably getting PCIs, and there's probably this Goldilocks of where somebody would get a CABG. Is that right, Mike?
Yes. So patients who are undergoing CABG do tend to have more severe coronary disease. They don't have a single vessel that could be easily treated with a PCI, but they also often tend to have more severe left ventricular systolic dysfunction, because we have data from the cardiology literature indicating that LV dysfunction is a marker for better outcomes with CABG as compared to PCI. So you're right, Eric. These tend to be different populations, and therefore this needs to be dealt with in the context of the paper. And so I'll turn it back over to Liz.
So
Yeah.
Liz, statistics were done.
Yes. Well, I actually want to point out one thing, because we can certainly complain that PCI and CABG recipients are not well matched at baseline, and then you can do some math magic, and now I tell you they're perfect, whatever. But actually, there's a fair amount of comparisons in the literature looking at cognition specifically after CABG that didn't use a group of people with heart disease at all. They compared it to, people recruited from a senior center. And they said, hey, these people who had heart surgery did worse cognitively than healthy older adults from a senior center. So actually, one of the things that I specifically wanted to do in this work was find an appropriate control patient population for people who had severe enough cardiac disease to need revascularization. And for that, the obvious control group is PCI, not just, medically managed cardiology patients or healthy older adults waiting for a knee replacement.
So how did you account for, or did you account for is the differences between indications between the two groups and who would get it?
We weren't able to account for cardiology indications. We don't have left ventricular systolic function. We don't have, what territories were impacted by the coronary artery disease. But we have, diabetes, hypertension, prior stroke, some measures of functional status, independence and activities of daily living. We have a palette of factors that we could try and balance for, and we did that using statistics. And we used a second methodology called propensity score weighting, where we tried to calculate how likely someone was to get a PCI versus a CABG, and then kind of upweighted the people who looked like, to match the cohorts better. Because we could alternatively try and use math to make them look like a fake randomized trial to kind of balance that. It's a slightly different methodology, though, also based on regression modeling. So we tried two different ways. They agreed, which was reassuring.
Yeah. Mm-hmm. And then I guess the question is, what did you find?
So the primary analysis, what we said we really wanted to study was whether the rate of cognitive change prior to the surgery or PCI was different from the rate after surgery or PCI. Did you have an acute change in your cognition at the time of your revascularization procedure?
And Mike, real quick, before you read this article, what do you think that they would have shown?
So I was surprised at the results of the article. I expected that patients who underwent CABG would have more rapid progression of cognitive decline. However, that sort of underscores the importance of this paper. And part of the reason why I would have thought that is that, as referenced in Liz's paper, I think it's the first reference, there was a paper in New England Journal about 20 years ago, which indicated that following coronary bypass surgery, there was a significant rate of cognitive decline and that it persisted for several years. And I actually referenced that paper in many review articles that I wrote, book chapters on this topic. Later, it became, those findings were questioned for the exact reasons that Liz is saying, is that they didn't have any information about the preoperative rate of cognitive decline to compare the postoperative rate of decline against. And so that's, I think, a very novel aspect of this particular study, looking at the rate of decline before the procedure, after the procedure, has there been any significant changes? And perhaps more importantly, were there any differences between the PCI group and the CABG group?
So Liz, what did you find?
That no difference, right? So if you model a cognitive change or potential for cognitive change at the time of the procedure, there is none. In whether you have a CABG or whether you have a PCI. And after the procedure, the rate of cognitive change in both groups was totally indistinguishable. The lines are basically right on top of each other. So based on this, after looking at whether there was an acute change and whether the long-term cognitive outcome was different between open heart CABG surgery and PCI, there's no difference.
So this was out to 5 years, and I think it's very reassuring for us as cardiologists. We can tell patients, well, we now have good data, acknowledging it's not a randomized trial, but we have good data indicating that the rate of cognitive decline following bypass surgery is no different than it was had you not undergone bypass surgery, and no different than if you have PCI instead. I think that that's clinically valuable information for cardiologists and also for other clinicians, geriatricians and others who are talking to their patients about some of these options for treatment of their heart disease.
And we were thinking that if there was going to be a difference, we should see a really big signal, because when you have a CABG, you're exposed to a tremendous number of things that we think should be cognitively impactful. Obviously, anesthetic medications have been implicated in vitro, particularly studies. So you're exposed to general anesthetic, you go on the heart-lung bypass pump, or you have, a surgery without the pump, which we could talk about later. You go to the ICU, you're intubated with a breathing tube. You probably have higher rates of postoperative delirium, which is reliably associated with adverse long-term cognitive outcomes. You're in the hospital longer, you're healing this trauma, it's inflammatory. There are tons of things that should make your cognition worse after CABG compared to PCI. And the fact that we saw them so tightly opposed is really remarkable.
And Mike, when you think about this from a geriatric cardiology perspective, this article, does it change at all how you think, like your practice or where we should go from here? Or do you still have a lot of questions about the article?
Yeah, so I think that an important limitation of this paper, and I'd like to hear Liz's thoughts about this as well, is that this provides great reassurance that overall cognitive function is not really significantly impacted by bypass surgery over the long run. But we still do have the short-term effects, which we certainly know that delirium is going to be much more common after bypass surgery in this population compared to those who are undergoing PCI. And so I think that still is an important aspect of it. I think we can reassure our patients about the long-term effects, but we still have to deal with the higher risk of these important cognitive effects in the short term following the procedure, and what we can do to minimize those effects, minimize the occurrence of delirium. And if it does occur, how do we optimally treat it?
Yeah, I completely agree with that. And we very deliberately did not make any conclusions about the immediate postoperative period, because there's no reason to think that somebody who's had their chest cracked open would feel totally back to normal 6 weeks later, even, although we would hope that for our patients. That's a big trauma. That's a big deal in your life. And compared to PCI, where you probably would feel pretty much back to normal, it's just not fair to compare those. So older adults should be warned that there are a lot of things that can be pretty unpleasant about postoperative recovery from a CABG, but there's no evidence based on this work that the long-term cognitive outcome is bad. And there had been some questions about that, whether, 5 years after a CABG, maybe that's when you sort of manifest a higher rate of dementia. We modeled that and also didn't see a difference there. But if the CABG revascularization is the right one for the heart disease that you have, and you're an appropriate candidate, there's not a cognitive reason not to proceed with that for long-term outcomes.
I think another important observation from this study was the comparison between off-pump and on-pump bypass surgery. So off-pump surgery became popular in part because of this New England Journal paper in, I think it was 2001, and the concern that maybe it was an effect of the bypass pump itself that was impacting cognitive function in these patients. And so off-pump techniques were developed. And what did you find in this study on the comparison between off-pump and on-pump?
So we had a pre-specified comparison between on and off-pump. And the hypothesis going in should be that off-pump CABG, which was in part developed to avoid the hypothesized cognitive impact of cardiac bypass pump exposure, the hypothesis would have been that the off-pump people would do better. And in fact, we found that the on-pump people did better. The off-pump people were the only ones who had an acute change in their cognition, an acute worsening of cognitive trajectory that, if you model it out, was sustained until the end of the modeling time frame.
I think
Why
that
is
has
that?
very important implications for surgical practice and surgical anesthesiologists and pump technicians and so forth, that probably off-pump surgery, at least with the objective of trying to minimize post-op cognitive change, should be pretty much abandoned based on this study.
Yeah, and I kind of want to, if you'll let me, I'll talk you through what it feels like to be in the OR on the anesthesia side during an off-pump CABG.
Yeah, I wanted a visual of what's that like surgeon trying to operate on the beating heart.
Yeah.
Well,
So
the one
I'm
thing
not
I did
a cardiac
learn from Liz was that anesthesiologists have a very hard time picking songs. I'm guessing that comes from the OR, who gets to decide who plays
we're
the
never
song.
going to pick the music. It's very nerve-wracking for us.
Sorry, Liz, go ahead. Tell us what it's like.
Well, so I was exposed to off-pump CABG through my residency only. I'm not a cardiovascular anesthesiologist. That's a specialty of anesthesia. But through my 2 months of cardiac anesthesia, what I remember is off-pump CABGs are terrifying for the anesthesiologist. They can be, because as you point out, Eric, the surgeon has to operate on this beating heart. But the heart has not conveniently put all of its blood vessels in the front where you can kind of get to them. There are special devices that are trying to stabilize the heart. It's not perfect, but it's pretty good. But where it became really nerve-wracking for us was that the surgeon sometimes has to kind of lift up and twist the heart a little bit, and you'll watch the blood pressure go down. And eventually you're like, okay, please, untwist the heart, let them reperfuse, let the heart recover. We'll give them a second. So these are really alarming cases for the anesthesiologist, although people still do well afterwards. There are good, revascularization outcomes after off-pump CABG. They're not as good as after an on-pump CABG, where the heart is stopped, the bypass pump takes over, the surgeon gets to take as much time sewing stuff as they want to. And I will also say that for off-pump CABG, you need to come in a little bit better than for an on-pump CABG, because you need to be able to handle having very low cardiac output for periods while the surgeon has to manipulate the heart in ways that it's not used to being manipulated. And we actually saw that when we modeled the cognitive trajectory for off-pump CABG recipients, they were cognitively doing better than the older adults who got on-pump surgery or PCI. So you can see a little bit of WAG where their preoperative trajectory was slightly better. And that jives with knowing that these people have to be a little more robust than somebody who's getting an on-pump CABG, because they've got to be able to survive these pretty significant swings in blood pressure necessitated by the surgical positioning of the heart. Unfortunately, we then showed that they dipped below the other groups on average postoperatively.
Are there any other better why else would you choose off pump? Like, are there other studies showing benefits from other aspects besides cognitive function, which I guess this study did not show?
Mike, I think postoperative atrial fibrillation is less common in off-pump CABG.
I'm not certain that might be the case. And I really don't know currently how often off-pump is being used, but I think it still is being used, at least occasionally by some surgeons.
As we were just talking about, there's this big concern about the cognitive outcomes of bypass surgery, and there are some articles in the New York Times and other news outlets that really blew this up. Started talking about pump head, being on the pump and having cognitive decline afterward. So I guess, just for in simple terms for our audience, not that our audience is simple, but just give us the headline. Is pump head a thing? What does your article have to say about that?
Oh, Alex, I wish I could give you a straight answer. You thought I was just going to give you a yes, no. I'm not. So you have to remember that what we've done is model average trajectories. So on average, everybody averaged together, there's no difference between CABG and PCI. But that doesn't mean that some people don't have what we would consider an adverse cognitive outcome from CABG or from PCI for whatever reason. And so I'm not going to say that nobody gets pump head. And pump head is sort of this amorphous syndrome-y kind of low cognition, subjective memory complaints. We call it pump head. It doesn't necessarily come with a diagnosis that's clearly causal, but I think what we've learned in the last few years is that perioperative covert stroke, for example, is relatively common. And certainly one of the things people worry about with the bypass pump is embolizing material up to the cerebral vasculature and causing covert stroke. So you could say, on average, there's no evidence for an average population level public health problem kind of decrement in cognition after bypass surgery. But we also did a post hoc analysis that showed that some people in the CABG group and some people in the PCI group have bad cognitive outcomes after revascularization for whatever reason. One of those might be perioperative covert stroke, and perioperative covert stroke may be more common with a bypass pump, or it may be more common if your heart's being twisted around and you embolize little things from your crunchy aorta from your cardiac disease.
So I would say that in my experience, a certain proportion of patients undergoing open heart surgery, whether it's CABG or valve or whatever, will experience a period of fogginess after the procedure for some period of time. I agree completely with Liz that the genesis of this is not entirely clear, whether it's related to pump or anesthesia taking a long time to wear off or some kind of other insult to the brain. I think that is a real phenomenon. And for most of those individuals, it will resolve over a period of no more than a couple of weeks, 2-3 weeks, and they'll say, yeah, I'm pretty much back to normal. I felt foggy after the procedure, and their family will say they're foggy, but it tends to resolve completely as far as the patients are concerned.
Mm-hmm. So I got another question. One of my last questions. So the article that Alex mentioned earlier that we presented at the AGS updates talk was from Dae Kim looking at TAVRs and functional status after TAVR. Because we always hear these stories, like people get better after TAVR, everything's great, it's this non-invasive procedure. But Dae Kim's article basically looked at this, and what he basically found was that post-procedure function is driven by pre-procedure function. So it actually didn't, this idea that restoring cardiac output significantly improves function may be somewhat unfounded with TAVR. Are we seeing potentially the same thing here? Is like pre-CABG kind of cognitive function kind of determines like post-CABG cognitive function?
Yeah, so we did see that people with lower preoperative cognition were more likely to be in kind of the worst categories for cognitive decline after surgery in the post-hoc analysis. So having preoperative low cognition continues to be demonstrated as a risk factor for post-operative low cognition. And yet it's not quite helpful enough to tell us who's going to have a poor cognitive outcome post-operatively. So not surprisingly, yeah, people who have worse cognition pre-op tend to have it worse post-op. But I don't know that necessarily matches up very well with the people who say, I am different after surgery. There's a sort of subjective post-operative cognitive change that hasn't been investigated much, really at all. And comparing that to objective cognitive change and to people's preoperative cognition, either measured or subjective, gets a little confusing. And we've mostly been studying objective measured versus objective measured. I'm not sure that's always giving the answer that patients are looking for.
Mm-hmm.
I think it raises an interesting point. I think that, as Eric pointed out, in the TAVR population, I suspect the same thing would be true in general in cardiac surgery patients, that preoperative functional abilities are predictive of postoperative functional abilities, regardless of what the procedure is. And so that has led to some interest over recent years in what's called prehab of conditioning prior to the procedure. And John Affolalo is currently doing a prospective randomized trial in Montreal. It's actually a multi-center trial throughout Canada, looking at a prehab intervention which involves exercise and nutritional support to see if it will have an impact on functional status after specifically TAVR. But that raises sort of the thought that, if we can identify the people who have worse cognitive function or lower cognitive abilities or on a steeper cognitive decline trajectory preoperatively, is there anything that we can do to try to mitigate that effect on the postoperative cognitive decline? And I don't know the answer.
It's a really important question, though. And it's certainly there are people in the anesthesia space studying this, but it's tricky because these are intensive, costly interventions. And you really want to be able to identify the people who would benefit. And we don't have a good way to, for example, measure a cognitive trajectory before surgery and say, you're not a very good one. Like let's have you do some computer games or something. Similarly for function, you can ask some questions, but you can't always drill down, I think, to the people who are going to benefit. And that's certainly a focus of identifying those people so we can improve this.
So is it okay if I kind of move on from this article to kind of my last questions on this? Alex, do you have any other questions?
No, let's move on.
Okay. I'm going to turn to both Mike and Liz so we have, a lot of generalists on this podcast, people who are working with older adults, people with serious illness. Is there one or two things that you wish people knew, either about geriatric anesthesiology or geriatric cardiology, that we should be incorporating kind of in our own practices? Mike, or if you had like a magic wand that you could make a change to one thing, like what would you use that magic wand on? Mike, I'm going to turn to you first.
Well, I would use the magic wand on cardiologists, not on...
Okay, what's that magic wand? What's the one thing that you would use on the cardiologists?
So on the cardiologists, I would want them to take a more patient-centered approach and think beyond their cardiovascular disease and think the fact that this patient has multiple other issues and their heart disease is perhaps only one of them, and that they need to talk to the patient and get a sense of what's important to the patient in determining what the best course of treatment for their cardiovascular disease will be. The same applies to geriatricians, but it's like preaching to the choir and talking about those things for the geriatricians.
Although I guess it's a caution to the geriatricians, those taking care of older adults with your primary care doc or your palliative care doc, that when you're working with a cardiologist to make sure that they're focused, helping them to focus on the bigger goals, aspirations, hopes, dreams, wishes of the patient, rather than the single, the pump or the vasculature.
Yeah, I don't want to indict cardiologists, but I think that the way cardiology is structured, there is a tendency to look at diseases in silos. We have guidelines for each different disease, atrial fibrillation, heart failure, and so forth. Follow the guidelines, and you're just treating that disease. You're not treating the whole patient. And so I think that there just needs to be a broader perspective on caring for older individuals who have more than one silo disease.
Mm-hmm. Liz, how about you?
Well, I think that this paper and this analysis is actually really important in understanding average causal impact of major surgery on long-term cognition, because this is one of the most, provocative surgeries for cognitive change that we could think of. And we didn't see that CABG changed your longitudinal cognitive trajectory. There are older adults who don't seek out functional improvement through surgery because they're afraid of the cognitive impact. There's this feeling, this dogma that surgery and anesthesia are bad for older adults. Mm-hmm. And I don't want that to be, what keeps you from getting a knee replacement when you've had functionally impactful osteoarthritis, you're on opioids, you're not sleeping well, you can't exercise or go ballroom dancing with your friends. Like, talk to a surgeon. If you're an appropriate candidate, there's very little evidence based on this work that an episode of surgery and anesthesia that goes well, that fixes a problem, is going to change your long-term cognition. Mm-hmm. And so, leave it up to the people who know you best and yourself to understand whether this functional improvement that you're hoping to accrue from surgery, balances out the other potential risks, because on average, there's not, a hit to your cognition for older adults having major surgery.
And I guess the functional equivalent would be if you're an older adult who gets chest pain when you're walking around, but you're trying to avoid surgery because you're afraid of the cognitive outcomes, at least you should go talk to the cardiologist, talk to the anesthesiologist, talk to the surgeon, maybe reconsider that in view of this paper.
Yeah, see if it's the right thing to do.
Well, Liz and Mike, big thank you for joining on this podcast. Alex, little Bee Gees. I think you're right. Before I get a lot of emails, I think the Bee Gees are from Manchester, but
okay.
Somewhere.
Listeners, don't email Eric.
Don't email me.
I can still feel the breeze that rustles through the trees and misty memories of days gone by. We could never see tomorrow. No one said a word about the sorrow. How can you mend a broken heart? How can you stop the rain from falling down? How can you stop the sun from shining? What makes the world go round? How can you mend this broken man? How can a loser ever win? Please help me mend my broken heart and let me live again.
I think from now on, we're just going to do BG songs in the future. Excellent, Alex. I'm going to email all our future podcast guests. Stick with Bee Gees. Well, Mike and Liz, big thank you for joining us on the Jerry Powell podcast.
Thanks so much for the invitation. Great to speak with you guys.
Absolutely. Thanks very much. It's been great fun.
And a big thank you to Archstone Foundation for your continued support, and to all of our listeners. Thank you for supporting the Jerry Powell podcast. Good night, everybody.